Once we've taken detailed history and examination and our diagnosis, our primary diagnosis pointing towards the Osteochondritis Dissecans, then we need to confirm our diagnosis by certain imagery. First and foremost in the imagery comes the X-rays, and we have to get an AP and lateral view while standing of the knee joint. Why AP and lateral is important? Because on AP view we would get to know what exactly is the pathology over there. Is there something wrong with the patella? What is the situation, fibula, tibia, and both the femoral condyles of the femur? As I told you, the most commonly, about 60 to 70% of the time, it's always on the posterior lateral aspect of the medial femoral condyle. Therefore, you have to look at the medial femoral condyle clearly, and there may be a gutter-shaped, a cravat-shaped lesion which may be seen on the posterior lateral aspect of the medial femoral condyle, which may present with increased sclerosis. And you can also appreciate maybe there may be osteochondral bone which may have separated out of the normal condyle. Other options which we can go for is usually called as MRI. Why? Because MRI actually confirms our diagnosis. Also, we are able to exactly diagnose whether it's a stable lesion or unstable lesion. And further, we are also able to understand what is exact size of the lesion. This is an image which is an MRI which is showing this. If you appreciate it over here, you can appreciate this is where the problem is. And can you appreciate this is the cartilage which is actually softened up as compared to the other area, and this is subchondral bone which is actually separating gradually from the underlying meniscus. If you appreciate clearly, there may be on other images like T2, you may appreciate increased edema or any other problems associated with it as well. But actually MRI is important to check the stability of the lesion. If it appears to be a stable lesion, our treatment may be very different, but if it's unstable lesion, our treatment may vary greatly as well. This is an X-ray which is showing an AP view of this. If you can appreciate it over here, this is patella, this is fibula, this is the medial femoral condyle. And can you see a crater or a cup-shaped depression in the osteochondral bone? This is actually showing an osteochondral fracture with increased sclerosis of the subchondral bone, and there is loss of cartilage over here as well. And this crater or cravat which has been formed is due to the osteochondral fracture leading to Osteochondritis Dissecans. Now this is another X-ray. Now if you appreciate this, the previous one, you can only see there is a small cup-shaped lesion. A whole of the femoral condyle is very much intact. But sometimes it may progress with this sort of a problem, like if you see it over here, can you appreciate that almost there is a lot of loss of the medial femoral condyle as compared to the lateral one. And instead of having a cup-shaped lesion, actually the whole cartilage has eroded along with the erosion of the subchondral bone. And this is sometimes it may present, it doesn't really looks like a large lesion, but if we get an MRI, we would clearly appreciate what is the size of the lesion. And that is why once we've gotten our X-rays, we have to go for an MRI to exactly assess the size and stability of the lesion, which is very important. Therefore, when we are going for the imagery of the Osteochondritis Dissecans, first and foremost are always the X-rays, which is the weight-bearing views, AP and lateral view of the knee joint involved, as well as the MRI of the same knee which is getting involved as well.